Okay, a little intro to today's session. It's really interesting to me. We were doing the E word, endometriosis, women's health issue, obviously. I just want to talk a little bit about this in reflection after having done this interview. I'd say a few things, Kayla, as a male.
Yep.
Endometriosis is not a barbecue conversation.
Tell me more.
Well, you don't go to a barbecue and talk about people's endometriosis, especially men.
Yeah.
In fact, it's by not being just not a barbecue conversation, it's generally not a conversation.
Yeah, very hidden disease.
I'm not really aware of it. I was interested to learn that it's probably more like 1 in 7 women of reproductive age suffer from endometriosis. I'll give you another few facts as I understand them that I've come to learn, and I'll tell you what I make of them. So 1 in 7. It's a disease that has actually no real known cause. There are theories, but there are no known causes. Of course, when you have no known causes, you don't have very many known cures.
Yep.
So your symptoms are painful.
Yes.
And they range from severe period pain, but also because this tissue escapes into the rest of the body and starts growing randomly in places, and it's basically adhesive. There can be constant pain beyond period pain. Things like organs being adhered to other organs and so on and so forth.
Yes.
There can be severe pain, especially with things like sex, which is obviously going to ruin your life a bit.
Yep.
And the known treatments at the moment are really oral contraception of one particular type, the higher progesterone.
Yeah, and excision surgery, so removing that excess endometrial tissue from the uterus, but then also from the other organs, is another form of treatment. For women, it's not particularly pleasant to have to undergo a big abdominal surgery. Is kind of like your last-ditch effort.
Right. And the average, this is a stunning thing, the average time of first presenting in the medical system with the symptoms, which I remember are severe, affect every part of your life, and an actual diagnosis is about something like 8 years.
Yeah, globally, between 7 and 9 years from presentation of symptoms to diagnosis. And a lot of women will go undiagnosed for most of their lives.
Yeah. And what's your experience with this?
Yeah, so somebody who is in now year 9, still not had a diagnosis. It is, I think in the podcast, Deborah will talk to us about it being a whole person disease. It doesn't just affect you physically, it affects you mentally, it affects your intimate relationships. It's really challenging, and I think what's really important is that we are having these conversations, because a lot of women will spend most of their life hiding this, and as we talk about in the podcast, battling with this. And so if we can bring some education, bring some awareness so that people understand that many women in society, 1 in 7 of reproductive age, are going through this every day, every month, then I think that's a great thing that we can be doing.
Yeah. Okay, so guys listening, and any woman who don't really think much about endometriosis because it doesn't affect them or anyone around them, listen up.
Listen up.
So, guys, imagine you've got a affliction where your balls hurt the whole time, and once a month your balls hurt so much you can't get out of bed, and stuff from your balls escapes around the rest of your body and starts sticking itself to other organs, and then when you use that part of your body for other activities, it's terribly painful. This would be a barbecue conversation.
Oh, every man you talk to would be telling you about this if this was a thing that men were going through.
Yeah, and that's not a negative thing about men. In fact, it's possibly a good thing about men, but being health advocates. So, first of all, guys, have some
compassion?
Well, empathy or something, or actually help with this. I mean, it seems astonishing to me that we've got a disease that's not talked about, has no known cause, and the only things you can do are basically surgical or oral contraceptive, which doesn't solve the problem and actually has its own side effects.
Yeah.
I mean, what the actual...
If only science would make a leaping discovery in the next year, that would be amazing.
Yeah, but we don't put resources about it, and one reason we don't put resources at it is because we don't talk about it.
Yeah.
And it's because it's not a barbecue or a dinner table or a other conversation. I'm aware of a young woman who's a daughter from friends of ours who I suspect has this, and it's basically not something to be discussed. Like I keep getting told in whispers, "Oh, this is happening," but confidentially, no one wants you to know. And it's actually like, I understand that at an individual level, but at a societal level, we need to change it. Anyway, I'm now choking my own saliva because I'm so excited. So let's shut up and get into the rest of the podcast. And I was a little bit frustrated with Deborah on places because I think I wanted to get into the data and the cause and the known treatments and the efficacy of different supplements and stuff, none of which actually exists because it's not talked about. So, yeah.
So if you give it a listen and then share it with somebody in your life to raise that awareness.
Okay, well, welcome to a Prevention Cure podcast with me, Prof. Grant Schofield,
and Kayla Lenferna de la Motte.
And today it's our great pleasure to be joined by Deborah Bush. Hi, Deborah.
Kia ora, Grant and Kayla. Lovely to be here.
Yeah, so we're talking about endometriosis. And what's most interesting to me, I was remarking about this earlier going, well, look, I'm not in this field. A lot of people don't know much about what affects 1 in 10 women. What is endometriosis? How did we learn about it? And your remark to me was like, oh gosh, well, I've been in this field for 30 years. I thought everyone knew about it. So why don't we start? How did you even get into this field?
That's a really good starting place. And just a minor correction there, Grant. It's 40 years, which makes me 10 years older than you thought of. Which, it's a good feeling, but actually it's 40 years. So how I got into it, it was a really interesting move from being a teacher and a performer and being on the stage to coming into a field of gynecology. And when that happens, it's usually because of lived experience. And that was certainly the case for me. So in 1985, I had a diagnosis of endometriosis. And for someone who could articulate their symptoms and explain what I was going through, I just couldn't understand why I was fobbed off by doctors, why I was disbelieved, why I was told to almost get a life or find some hobbies. I was teaching full time. I was, I had a little boy of a little preschooler at that point. And even I think I had a remark to spend some time with my poor husband, the comment was. So I, coming from a family of community-minded family where we were encouraged to be involved and be advocates and so on, I just by chance, 3 months after my diagnosis, met 2 other women. And within a few months, we'd set up what is now Endometriosis New Zealand, but officially still the New Zealand Endometriosis Foundation Incorporated. So big, long name, and that's really where the journey started. But more than that, I think we set up seminars almost straight away, so 2 a year, is listening to other stories. Our stories paled into insignificance. And you've got to also remember, I think in those days, storytelling just simply wasn't a very cool thing. People with stories to tell weren't given much airtime. Wasn't really much space to do that. So you had to position yourself very carefully, learn the research, understand the disease, listen to the voices of those who were speaking. And quite quickly, we started to develop services and programs. I think I had my first international speaking engagement last century in Quebec, Canada. And that was about the education program, because sometimes you look at things and think, where can I add value? Where are my skills? What can I do? What can we do as a team that's going to view this disease differently, view it as a whole person disease, view it as a disease that isn't just all hidden as a silent disease, as it was often called. And actually, I remember that Time magazine, I think it might have been around about the circa 1990, wrote it was a front page article, and it had endometriosis, the white woman's career disease.
Wow.
I know.
Wow.
And, stunning things like that firstly irritate the stuffing out of you.
Yeah.
But secondly, think something has to be done. this is not just a nonsense in my country that I absolutely love passionately, but this is a global problem. And what's more, we could see that it was a public health issue. We were awarded the Commonwealth Award for Excellence in Women's Health, which was a wonderful sort of stimulus, a motivator, I guess, to keep going. And so the centuries are now, or at least the century turned over, the decades are rolling on. And so I was always looking to think, how can we better ourselves? How do I actually, my purpose, where do I sit in all of this, big story, that's this big global story that's endometriosis. So there was a quick overview of my journey with endo. Actually, I don't know whether people want to know, but I ended up with 3 major surgeries. So laparotomies rather than laparoscopies as they would be today. And the final one was at 28, having a laparotomy with hysterectomy, bilateral oophorectomy, so both ovaries, and a bowel resection.
Wow.
So I was going through menopause at the same time as my mum with no hormone replacement therapy.
Mm.
So pretty tough times. But
Is that still a standard? I mean, does that still happen at all?
Yes, it does.
Yeah.
Yes, certainly in my coaching role, I see many women who have having or just had a hysterectomy for largely endometriosis, but we also probably need to, let's go back and talk about endo, because we're probably thinking, what on earth is this thing? So
Yeah, let's do one. Can we do endometriosis 101?
Let's do that.
Who gets it? Why do they get it?
Yeah.
How many are getting? Is it getting more or less? Let's talk about all of that.
Let's do that. Endometriosis. So quick explanation for a complex disease. Endometriosis is where, if you can imagine the uterus, so the lining of the uterus, where tissue similar to that, not the same as, tissue similar to the lining of the uterus is found outside the uterus where it should not be. And that tissue can sometimes be what we might call superficial. So it sits on top of organs or structures, or it might start to infiltrate. So we start to see the different stages of disease, being from mild to superficial to infiltrative disease. And when I say that, it might mean that it's starting to infiltrate into other tissues or even other organs. And in some cases, just causes a right royal mess of the anatomy and distorts the anatomy. Along with that, adhesions are common. So you get adhesions are kind of, I describe that to my the patients I see, a bit like rubber bands or cobwebs. You get bits sticking to other bits that shouldn't be stuck. And so when you get the bowel adhered to the pelvic sidewalls or the female structures in the pelvis, you often get bowel involvement. And you get what I often call to grumpy pelvis. You get, the organs in the pelvis get really grumpy. I mean, you'd be really grumpy if you were stuck somewhere where you weren't meant to be stuck. So you can see that there's the disease. And
hang on, so
Yeah.
let's get this clear. This is sort of akin to someone running around your insides with contact adhesive or something and squirting against your bowel, and then that accidentally sticks over here, or putting a coating of this on. So can it end up on top of your kidney or your liver? Or
it could end up with the pelvic sidewall stuck, or the back of the front of the uterus stuck in the fallopian tubes, or the quite commonly what can happen is that the ovaries will stick or be adhered to the pelvic sidewalls. So you can imagine that can cause extreme pain. It distorts the anatomy. It can be one of the causes of infertility. You can imagine if the ovaries are stuck somewhere where they're not meant to be, then, it can distort that natural fertility happening. So you're quite right. Actually, Grant, it's so interesting when you said that body glue. I work very closely with a professor of gynecology in Auckland, and he often calls adhesions body glue. So, yeah.
And so how do you get a diagnosis? And then can we jump from there to, do we know what the cause is?
Mm. So traditionally, certainly in the last few decades, diagnosis has been by way of laparoscopy. So a surgeon or gynecologist needs to view the pelvis and see the disease. We're actually learning so much more about the disease now. You can see the complications of that, can't you? A patient might go and present to their GP. They've got all these symptoms. The GP thinks, gee, this might be endometriosis. Let's refer you to the hospital. If we're looking at what we would want to happen, the hospital says, yes, we'll accept you and we'll do a gynae review of your case, and then a decision is made whether to proceed to laparoscopy or not. It isn't like that really today. And most of the guidelines say, look, let's make a working diagnosis, it's often called. We hear the story. We ask some pertinent questions like family history, because this does run in families. We can't say, here's the genes, but we do know there's a very strong familial link with endometriosis. But we can
So
say...
you can't be diagnosed with a cluster of symptoms. Is that good enough?
Well, a cluster of symptoms is going to give us a working diagnosis, isn't it?
Yeah.
Not a factual. We haven't visualized the disease in the pelvis, but we've got enough information. You're quite right, Grant. I really like that. So there's enough information to go on to make a working diagnosis, to say, look, we strongly think this is endometriosis. And our first line approach to that is usually hormonal management.
And what's the reason for that, Deborah, that that's the first line treatment and not anything else, for example?
One of the things, Kayla, is that if we look at saying, well, it used to be just put them on the pill.
Yeah.
It's not just any old pill. The guidelines generally say, let's use a progestin type based pill rather than a combined oral estrogen progestin base, because we know estrogen is one of the triggers for endometriosis. So that's what the guidelines really tell us now. When you ask that question, Kayla, it kind of it put me on the spot a wee bit, and I'll tell you why. Because it would be lovely, wouldn't it, to have another first line treatment?
Yes, I was looking at the guidelines, and that's why I kind of asked. I thought it was really interesting that for all of them, I've just got them here in front of me, for all of them, except for the international consensus was the only one that talked about an individualized treatment approach. Everyone else talked about hormone therapy first line, and then the international consensus talked about this individualized approach. And I thought, oh, wouldn't that be wonderful? And what would that look like?
Well, the consensus document I know well, because I was part of it. We did it when we were at a conference in Montpellier in 2013. I think we've jumped a step. So the consensus document said, let's sit down with the person who we suspect has endometriosis. And we say, here's some of the things that we could do now with a suspicion of endometriosis. And so what the guidelines have done is jumped to the hormonal treatments. So you can see that I think that's a beautiful way to start. And I'm glad you raised that and had looked at that document, because it's quite outdated when you think about it now. It's 12 years old.
Yeah. Well, I was surprised at how ahead of its time it was, I think is where I'm going. I mean, I've had personal experience with endometriosis, and if I had had that discussion as my first line treatment, what a difference that would have made for me. And I just...
Isn't it wonderful that we can actually, and I think, that is actually where we're going to sit down, because a patient's goals are not always the same as a clinician's goals.
Yeah.
You know, in my experience and my well health coaching hat on, when I ask people, you know, what's important to you? What would you like out of them? Very rarely do they say, I want another surgery.
Yeah.
They might say they want help talking to their family about what they're going through, or they want help to be able to stay at work every day, or want help to be able to go to school and not be impacted by the symptoms that they have. So it's a crucial one, and I'm so glad you raised that. And you know, took me back 12 years. I can actually visualize the room and the space that we were in at the time. So thank you. And it is a lovely starting place. Let's sit down. Let's think about your symptomology, what you're presenting here with, and then discuss a possible course or a plan for you that looks like it's going to work.
So hang on. So I just want to take one step back before we get into this. We do need to go back to sort of prevalence causes,
Yes.
but I just wanted to reflect on one thing that you mentioned earlier, and I think this is a sordid history of poor women's health, that I imagine what must have been happening even before this part of medicine is that the whole idea that women would report with a bunch of symptoms, they would get a hysterectomy. And just to be clear, that name came from the removing of hysteria,
Yeah.
an appalling name, and you know, a pretty invasive and big procedure. And you know, just to reflect for a moment on the fact that probably happened to thousands and thousands of women.
Yeah.
I think probably millions.
Yeah.
Millions. Grant.
And so, like, while we've come a long way, I appreciate that's part of the journey, and we've got a long way to go. What is the cause? Is there a known cause? Because I think that's, and who gets it? Why do they get it?
Yeah. So the causes are multifactorial, we say. In other words, there's probably lots of reasons. So one of them is going to be the familial component. And the other one is, you know, in days gone by, actually, it was Sampson's theory, and I think that will be 100 years ago. Oh my gosh. So 1925-ish. This guy, John Sampson, decided that endometriosis was caused by what it was referred to as retrograde menstruation. In fact, blood that backflowed through the tubes and fell out of the bottom of the tubes and embedded itself into the pelvis and the pelvic organs. And while we know that is actually a thing, which is incredibly interesting, isn't it? It is actually a thing. I think it's more than, it's 90-ish% of women who menstruate, or people who menstruate, have some sort of reflux or retrograde menstruation. Whether it actually becomes endometriosis is another matter. And that's the big, robust debate that continues to happen. There are some researchers, academics, and gynecologists who are firmly embedded in that story. And there are others who are firmly so against it, saying it just doesn't make sense. So I think that, but we have to talk about that as a possible cause. And is it? Well, the research is still out there on that. So we've got familial, we've got the retrograde menstruation theory, we've got the immune theory. Now that's quite an interesting one that says there might be some link to the an ill-functioning immune system, but we don't quite know what it is. And whether it's cause or effect, I think that's kind of a really interesting association. You know, it was last century, I can remember it was about 1998, they did a big study over in the States. And it looked at, you know, the other immune-related disorders that people could present with, asthma, you know, those sorts of things, asthma, eczema, hay fevers, irritable bowel syndrome, all those things, and said those with endometriosis had a higher proportion of those immune-related disease or conditions than the normal population. Now, you can't actually say, though, that it's cause and effect.
Yeah.
We don't know. There is no proof
So
about.
is there autoimmune antibodies that you see? Or I suppose if you've got some of these other things, you would, but
Mm.
and it makes some sense in terms of some of the other, when we looked at some of the other, effective dietary treatments, they talk about an anti-inflammatory diet, and I suppose we're trying to dial down the immune system. That makes some sense in that paradigm.
Yeah.
It absolutely does. And, I don't think we can draw the line through any of the things. There's another Mullerian theory that, little wee newborns who perhaps are born having a period, is that something that triggers endometriosis from, the first menstrual period? We don't know. That is the biggest thing I think we can take out of this conversation. We actually don't know the cause. I like to leave that up to the very, very clever scientists and academics who are doing lots of work in that area, but say, okay, we know some of the causes, the possible causes of endo. We know it's probably multifactorial, but what can we do about it?
Because there are other clues in that, though. So I suppose if you go, well, are there different environmental triggers? Is it higher prevalence in different parts of the world? Does some woman get it more than other women do? Some people report, dietary this or, deficiencies on that. Or is there any evidence around that?
Yeah, I really like the track that you're going down with that, Grant, because it's really relevant. I can remember being at a gynecological meeting at the start. It was somewhere, it was probably about 25 years ago in New Zealand. And I was told by a gynecologist when I mentioned the field that I was in and what I was doing. And the person said to me, "You'll never find endometriosis in an African woman, and you will never, ever see it in a Māori woman." Now, that actually told me more about that person than the disease. And if you explore further, this is a huge problem right around the world. Asia, we've just come back from the World Congress in Sydney on endometriosis. It's a massive problem wherever you go. I think the reason for that is as a poor presentation in some settings. So people suck it up, they put up with symptoms. They are often culturally, it might be a cultural aspect, it might be embarrassment, it might be all sorts of reasons. But going back to that Time magazine, remember, the white middle-class career woman's disease. It was probably that presentation. It was those people who were presenting with symptoms, rather than this is the finite group who have endometriosis. So, we've been battling with that for a long, long time. In fact, I think the biggest take-home message from this particular part of the conversation we're having is that endometriosis doesn't discriminate. It's been busy disrupting the lives of people around the world and for centuries. And so no one really is exempt, and no particular culture or race is exempt from having this disease. I think the biggest, the data that we know is, you mentioned at the start, Grant, was 1 in 10. That data tracks back now to about 2010. Australia have just done some very interesting data that they report at about 3 years ago. They were saying it was 1 in 9. In the last 18 months, they've done more studies, and they're saying actually it is 1 in 7. And that's the statistic that they particularly use in Australia.
I have a question.
Do you reckon some of those, like when they go with type 2 diabetes, you've got the people that know they've got type 2 diabetes and the people who have got it who don't know they've got it? Is that, what's that divided up like?
Yeah, well, that's where my brain was going. Is prevalence increasing, or is the stigma reducing and more women are presenting as the stigma around the disease reduces?
Look, we've been doing a lot of work for 40 years in New Zealand. So in that, as part of the, we can talk about the programs and services later, but when you educate young people about symptoms and about, we do see earlier presentation that my research that was published in 2017 showed that very, very clearly. What happens when we educate people in a region over, and that was research was done over a longitudinal study of 15 years. Then we see more presentation in young people at our, for clinics. So when you raise awareness, you're quite right, Kayla. I know that's where you were going. It's a bit hard because we don't always have the hard data to prove what you are saying. But yeah, when we intervene early or recognize the symptoms early, we're going to see a higher presentation of symptoms. Did that get to where you were leading, Kayla, or did it sort of come through?
That was kind of where my brain was going, right? That
Yeah.
is this that it's becoming more prevalent due to the milieu of things going on in, westernized life, as westernized life takes over the world? And is there a chronic inflammation issue underlying? Are there comorbid diseases that could be raising the prevalence of the disease? Or is it just now that people feel more comfortable to present in the first place that our prevalence numbers are increasing?
And before you answer that, there's an additional caveat to that. Okay, so you talked about different cultures, but if I go to and I've done this work in the remote Pacific, if I go to the southernmost island of Vanuatu, most people are subsistence living with but no cell phones, no processed food, no nothing. And they have no chronic disease. They don't have autoimmune diseases. They don't have allergies. They don't have heart disease. They don't have cancer. They don't have depression. I assume they don't have endometriosis, but am I wrong there? I mean, in other words, is this a disease of modern civilization?
Look, I'm glad you clarified it with that one last sentence. Otherwise, I would have been struggling. Is a disease of modern civilization? Well, look, I could reach to my bookshelf and find my book that I've written, which is extraordinarily dilapidated and pages falling out. But so I did do the research on the history of endometriosis, and it's been done by other much more clever people than me. But when we look back in time, Hippocrates talked about this disease. So it was talked about, was called, believe it, the wandering womb disease. In other words, the womb wandered up to the brain and made the brain go crazy, caused hysteria. You talked about that word before, and made women go nuts. So
they're still semi-modern civilization. They're hardly hunting and gathering. Hippocrates.
No.
Yeah.
But when we think about, has it been noted? There was certainly in the Middle Ages a great resurgence of interest in gynae disorders, and this was one of them. So they didn't call it endo, but certainly when we hear the symptoms that they discussed, it's absolutely it fits the profile of endometriosis. But I can't answer your question from Vanuatu because I really don't know, Grant, but what an interesting study that would be.
Yeah, I suppose they're such small populations now and dwindling so fast. It's all pretty obvious with diabetes.
Yeah.
Because, that's half the population or insulin resistant nowadays, but endometriosis is another thing. So if we don't know the cause, how does that sit with people? I mean, if you follow the medical model, which we've often been critical of, not that it hasn't done some good, but then people are going, well, I expect medicine to know the cause and therefore the cure or the answer to this. And to me, it sounds like we're starting to now move outside of that.
Oh, we are. We absolutely are. And I think you need to, we can look at then view and review all the guidelines that we have at our fingertips now, including the New Zealand clinical pathway, the Australian guideline, the NICE guideline from the UK, ESHRA guideline from Europe, the consensus document. So there's a bunch of good guidelines that we can review now. And I think without doubt, they're all saying we need to recognise the symptoms early and intervene in a timely manner. And they're all saying a multidisciplinary approach to treatment and management is where we should be all aiming, because, you know, in the past, well, it was certainly in recent history, in recent times, it's been that we kind of make surgery the end point, and instead of it's just a piece, I guess, of the long-term care puzzle. And when you have people, like, the delay to diagnosis in New Zealand is 8.7 years from first presentation of symptoms.
Hang on, just say that again so everyone hears that.
The delay to diagnosis in New Zealand is 8.7 years. It's a study that we released, that I was an author on, and we released in 2022. Yeah, 2022.
I find that appalling.
It's appalling. It's a hell of a long time to wait in a queue. And remembering too that not everyone is going to present to their GP the first time they get symptoms. So they're suffering with these horrible, mean, nasty symptoms, might have been years in the making before they present. So if we've got 8.7 years, while it's shameful, Grant, it's pretty much fits with the world between 7 and 10 year diagnostic delay.
Wow.
Yeah. So yes, while it's shameful, we know that, but it just is a monumental problem, because we now have people who are, you know, on their phones, they're Googling their symptoms, they're coming up with, you know, I think I've got endometriosis. It may not be picked up by their doctor. In fact, because if they're sent for bloods and the bloods are normal, you know, should we move on to talk about what happens when you go to it? Would that be a good place?
Yeah.
I think we've said the word symptom. We've said the word symptoms and symptoms quite a lot, and we haven't actually nailed down what
Oh,
are
Kayla, like, so obvious. Thank you, Kayla. Let's do symptoms. I think that's a great place that we can veer off to now. So the most common symptoms with endometriosis are pelvic pain, and specifically period pain. And we call that dysmenorrhea, so period pain. And then we've got a bunch of other symptoms that seem to go along with that. So we might get, you know, heavy bleeding, or and certainly in my, you know, the young people I see have lower back pain. They get severe tiredness and fatigue. They've got bowel problems. So they're often told they have irritable bowel syndrome. Well, my question would be, why is the bowel irritated?
Yeah.
Because nothing else has shown up on anything. So let's just go through them again, because so we've got dysmenorrhea or period pain that actually interferes with your life. So it's not that kind of period pain where you take a couple of, you know, what pain relief you've got in the cupboard and get on with things. It's pain that can be quite debilitating. And that can be a bit subjective too, can't it?
Yes.
Because someone's pain here is different to someone's pain here.
Yeah.
But pain that stops you doing, you know, when we're doing the program in schools, we might pain if you're ever in the sick bay, if you're ever off work, if you ever don't do stuff with your family or friends because of your period. That's really not a normal period and requires investigation. And then you look at the other raft of symptoms like the tiredness and the fatigue and the lower back pain, and sometimes pain going down your legs, the headaches, the urinary symptoms. Some people present with chronic UTIs, or they've got, you know, trouble sleeping. But the biggest one is, or one of the big ones is bowel-related problems. So they might get diarrhea with their period, or they might fluctuate between diarrhea and constipation, or they get pain actually going to the toilet, moving their bowels. So they're doubled over in that kind of pain. Now, it's really interesting when we have a look at this raft of symptoms. I haven't included infertility there, but I'll come to that. When we look at this raft of symptoms, it might be for a young person, and she might be 12, 13 years old, just started a period. And one of the family members, it might be mum or grandma, say, all the girls in our family are like that. And you've got to suck it up and get over it. So you can see how we're starting to get to that normalization of symptoms.
Right.
You know, we're all like that in our family, love. Have a hottie. Here you are. And no,
Do
you
you
can't.
feel there's a significant proportion of women that have probably gone their whole lives?
Absolutely. One of the things that we haven't talked about there, and it's a good time to come in with it because it's a debilitating symptom, and that's pain with sex.
Mm.
And I think that, or dyspareunia is the medical name for pain with sex. It's a very personal, it's your intimate life. It's a very personal thing to talk to a doctor about. Culturally, then we might get a whole it adds another layer of complexity if you haven't shared that symptom because it's either too embarrassing or you don't want to talk about it, or well they didn't ask, so I didn't say. But when you get then the reason it's so relevant to endometriosis is that it can impact mental health, well-being, relationships, you know, and women have been called, when I was writing my book and doing the history of endometriosis, they're called barren, they're called frigid, they're called mean, nasty, horrible names that are so personal. Though, so for many women, having sex was like, that was about their fertility. And so it wasn't a happy, intimate relationship because so jolly painful. And one of the things that I work with my patients to show often why that's the case. You know, when we look at the female anatomy and we can see where this inflammation, endo causes inflammation, we can see where it is. It's understandable that having an internal examination or a scan or using tampons or having sex is going to be excruciatingly painful. And even for them understanding that is hugely reassuring. So, you know, that is an aspect, I think, that it leads me into this mental health because we talked about the pain. You asked about that, Grant. And the pain may come every month. And so for these days, every month, I get these symptoms. But endometriosis can quite quickly become a chronic condition. In other words, I've got random pain, or I have pain on most days of most months, and it's lasted longer than 6 months. And there is the chronic condition. And so it's very unlikely that a set of pills or surgery is going to fix that problem, is going to help you overcome the crippling impact that this disease has had on your mental health, on your well-being. Because if you're told it's all in your head, that does affect you. And it doesn't take very long for a very young person in their teenage years to become so frightened of having their period. And they start to work their life around it. No, they can't go for that sleepover that night, or they can't go to school camp, or they can't do that. These aren't one-off cases. I can give you the data from the research that from our study that we published. 27% of local Cantabrian young people were off school every or most months with severe dysmenorrhea, severe period pain. And that fits with global statistics too.
That's so interesting, right? You've done a lot of research and having a look at, you know, the mental health crisis in young women. And is this a big part of the puzzle?
Yeah, well, I think one interesting statistic for us, Deborah, that's perhaps unrelated but maybe related, is that when we've looked at psychological distress in young people, say 16 to 24 in New Zealand, then you know the most interesting statistic that was never discussed is that young women are always twice as high as young men on everything except for actually suicides, only because young men choose more violent means. So that's a whole nother sad topic. But For everything else, including emergency department presentations, young women are twice as high, and it seems to be not discussed as young women's mental health. It's not a topic in society. There's quite a lot about young men.
Well, you
Not-
know, this is where I suppose my career path has been really centered, and that's young people with dysmenorrhea and endometriosis, and why it's one of the absolute key things about why we need to recognize the symptoms and intervene early, for that very reason, Grant, that I know that those stats. And why is it, and has anyone taken it further to ask, why is it that young women actually have a higher rate of mental health than their male counterparts? And we need to be looking at this much with more clarity and understanding about menstrual health and well-being, and where it fits in this circle. Because if we've got 27% of our young people missing school every almost months, and we've got enough data, there's a lot of data about adolescents with endometriosis, and I present on this very topic right around the world a lot, because I think that we can actually crack this if we do recognize the symptoms early and intervene.
So is there evidence for that? Is there, like, the earlier you intervene, the better? And what does that intervention look like besides oral contraceptives? What else are you doing? And actually, I think we need to get to your journey of coaching and operating within that system, and how that's even come about, what that looks like. And then, just to overload you, and choose to answer this in any order. I mean, I appreciate there's not these large randomized trials of other things, but can you share anecdotes of women that have had successes at either, is there such a thing as remission? What sort of are the best case scenarios you can expect with different approaches? What have you seen that's been really, really good? Lots of questions there.
Yeah, look, I've got one, I've got case studies galore, but I can think of that young Laura, not her real name. At 15, she came to our clinic for her second laparoscopy, because the first laparoscopy revealed nothing. Between the first laparoscopy and the second, which were 6 months apart, she underwent significant mental health therapy off school, and when she came for her second laparoscopy, endometriosis was identified. So it was missed.
Is that common?
Yes.
Because that's even worse in many ways. It's like it's all in your head, love. See ya.
Yeah, that's right. Like we've looked and there was nothing there, and now we, off. So, and now she's 20, she's at university. So her path was actually talking through with the first thing is believe. Don't fob off. People don't want to make these symptoms up. So believe, listen to the story. Hear the story and put a set of just like you said at the start, Kayla, let's talk about what this might look like for you. We think it might be endometriosis. Here's our usual plan that we might follow. What would you like? And often it might be that, okay, it might be looking at a different type of hormone therapy. It might not. But we can, often they will want to try other things, and then they might come back to that. So it might be, in our clinic, of course, it's a tertiary referral centre, so we might actually see they want to go straight to the surgery. They've got private health insurance and all of those things. So that might be a different story for them than it might be in another setting. So, it's usually that. It's hormone treatment. It might be the Mirena, or the Mirena's baby sister, the JDS. Having that fitted, I think that's quite invasive for a very young person. So they might get a mild sedation. But depending on what their choice is and what they want to do. But it appears that if we try and minimize the number of periods somebody has, we tend to control the symptoms, as long as it hasn't become a chronic condition yet. So that would be one pathway, but it would be it would be remiss of us now not to look at the whole person. And it really irritates the stuffing out of me when I see, endometriosis and little hearts around the pelvis, because it segments the pelvis away to be, this is the disease, it's here. It isn't a whole body experience, and endometriosis is. So we need to look at the whole, all of the symptoms. If there's bowel symptoms, how about looking at a dietary?
Yeah. Okay. So speaking, let's talk about that.
Yeah,
Because we're quite into diets,
Yeah.
different diets.
Yeah.
So do you use that approach? Have you seen any success here? What does that even look like?
Yes, absolutely. But I need to declare at the outset, I'm not a dietitian, Grant. I just, on the
Okay.
fringe of dietary, so I have some knowledge, but I'm not a dietitian. So I just like to declare that at the outset to make it perfectly clear. The patients I see me for well health coaching. They see a dietitian as well. They might see a pelvic physiotherapy. So if we're looking at this disease globally in terms of the person, we're looking at their, I'm listening for things like, how long might they have suffered with this? And trying to jump out of that unwell mindset on their own can be really, really tough. Like, how do you do that? So they might need help with a clinical psychologist, or some people say, I want to come back and see me. That's fine, as long as they understand I'm not a clinical psychologist. And, they've enjoyed the first session they've had in that coaching arena that I do. And they might want to come back for multiple or a second or a third appointment. So we're looking at dietary for the bowel symptoms. And you were saying, well, what are the diets? Generally for endometriosis, we're looking at a FODMAP friendly or low FODMAP diet.
Yeah.
It seems to be that those particular carbohydrates can be irritants to those with endometriosis, or it might be looking at an anti-inflammatory diet. And a dietitian is going to take a much more refined way of looking at the food intake of that particular person. But you can hear, sometimes you only need to say, if this person says to me, oh, I get all bloated and feel revolting when I eat an apple. Now I'm immediately going to think, this is possibly a FODMAP person.
Yeah.
So, or it might be that they feel bloated and revolting, their terms, not mine, when they have a lot of bread.
Yeah.
Or a lot of carbohydrate, a lot of, toast for breakfast, sandwiches for lunch, and pasta for dinner. And you get that overload. So sometimes, you'll ask and make sure that there's been tests for Crohn's or tests for celiac and those sorts of things. But dietary changes, sometimes even minimal changes, can bring about such relief. And I think if you asked a lot of women who've been diagnosed, say, with that horrible irritable bowel syndrome, which is barely a diagnosis, isn't it? It's,
Yeah.
Yeah, 100%.
It's a
Diagnosis.
it's a set of symptoms. So when they have been diagnosed like that, and you can say, well, how about we look at that and we can relieve some of those bowel symptoms? That makes things so much better. Just looking at that. Or how about we can hear often in the story the lower back pain or the pain radiating up into the hip might be those, you can imagine if you're a pelvic organ, that you can get pretty grumpy if you've got an inflammatory disease sitting on or by you. So we're looking at those muscles going into spasm. And we've all experienced a spasm in our calf muscles, say. So, and the same things can happen with the pelvic muscles and the going into the hips. So a pelvic physio is going to be, so that's the sort of thing that I'll be listening for, and making sure that we're using the all our allied health professionals to be part of this person's journey, or certainly the ones who matter. Young people will generally have severe dysmenorrhea. It's often fixed by surgery and some medical management, and they get on. Disease has not yet become chronic. That's a generalization, by the way, but that would be my experience. in the people I've seen.
What I'm hearing, Deborah, is that as a coach in this space, you really provide continuity of care and connection into a really convoluted, sometimes hard to navigate system, right? And so being that singular touch point for people and building that rapport and actually just listening to them and what they need can sometimes give them the hope that, like, my life doesn't need to be like this.
Well, I think the word hope, I'm going to take that one word out of that lovely sort of summary that you did for us, Kayla. Hope is what people often want. They want to be heard and believed and listened to. Perhaps they want to cry. This has been a hard journey for them, and one that they've often, it's, you can hear it in the community. It's not a word I like to use, but my fight with endometriosis, my battle with endometriosis. And I think we need to be very careful about language, because all these messages are stored in the brain. I don't think it's a good idea to be fighting with yourself.
Yeah.
Yeah, that's a really interesting thing.
Yeah, so I've read a lot and I hear a lot about the language of pain, and you would have done that research and listening too, wouldn't you, Grant? And
We hear a lot about that with cancer as well,
Mm.
and I think people are now saying, let's not talk about your battle with cancer. A lot of people do much better when they go, well, I'm living with cancer,
Yeah.
and they get on and live.
And I'm living well with endometriosis.
Yeah.
And I'm not in a battle with myself. And I think, there's so many, we released some data, moving to a completely different topic now, but it's sort of, it feels like I've morphed along there. I've segued into it. So one of the areas of interest for me, well, I seem to have lots of them, but one of them is social media and endometriosis. And I will often ask the people I see, how many websites or Instagram pages for endo, and there are literally hundreds of thousands of them, are you following? Oh, they proudly might say, I follow all of them. No, it's a minefield out there. It's scary. Well, because everyone's fighting and battling, and what we're doing is reminding our brain. One of the first things a patient told me, I think it was about 3 or 4 weeks ago, it was very recent, was that the first thing she does in the morning is check how somebody might be who lives in Chicago, or then she switches to how somebody might when they're in their awake times, and then talking about there. So it's this constant brain reminder. I've got my pain switches here, if you like, and they're firmly on. So we often will talk about, how do we dial back the pain? How can we turn these pain switches off? What are the sites or the social media sites that really add value? And can we ditch the others? And because there's a whole heap of arguing that happens in there. It's a scary space. But some of it is really good. But some.
Yeah.
So that's interesting to me, because it sounds really much like the chronic pain approach at that point as well, which is an interesting thing. And is there evidence for that? Like you're getting a lot of pain, so you do get more sensitized to the same stimuli within endometriosis. That's an interesting thing, isn't it?
Yeah.
While we were talking about those pain switches and the pain receptors, I just kept thinking back to that wonderful metaphor from acceptance commitment therapy of dropping the rope, dropping the struggle. If you're constantly in a struggle, it's really hard. And where are the places in your life, whether it be on social media or what you engage with or how you talk about living with this condition, where you can just drop that struggle just a little bit so that you can live well.
Yeah, so relevant, Kayla. Thank you.
Yeah. So should we
I
wrap
just-
up? Or
It's one other thing I want to ask about,
Yeah.
the sort of communities and the fringes. I mean, it's interesting. Sometimes really interesting things can come out of there, and sometimes not so useful stuff can come out. But is it like, I've got no idea about this, so you can laugh me out of the room if you like. But do people go, you take omega-3 fish oils, that helps, or do you take turmeric and that? Are there practices around supplements? I'm generally not for supplements, by the way, but I'm just interested in that. Is that?
Yeah, absolutely. And often people in desperation will go to the health food shop and they'll fill their bags with everything in the hope that this is going to take away their pain or take away their symptoms, because they've heard that a particular supplement might be the answer. I'm going to drink this raspberry tea and my endometriosis will go. Well, the raspberry tea might be really nice tasting and it's got, it's a good value. I'm not downing that. It was the first thing that came to my mind. But some people might really like it, and it might be really good for health. Is it going to take away my endometriosis? That's most unlikely. There are quite a lot of, and I actually am going to take the raspberry leaf tea out and just say supplements in general are not going to be, they'll go out and spend exorbitant amounts of money in the hope that something is going to fix their endometriosis or cure their endometriosis. And they sort of go out with missionary zeal sometimes about, they might, post it all over, and then there's arguments in those social media spaces. And so I think with the supplement, I think we have to be careful. We have to think about the person globally. We have to call on the data and the science that we know. We have to call on the clinical aspects that we know, and we have to incorporate this wonderful wellness approach using allied health professionals to really give the best possible chance at somebody, being able to live well with their disease. And many people, yes, they will not have endometriosis again. But, I worked with somebody, it was a few years ago, admittedly, but a young person of 31 who had 19 surgeries.
Wow.
19.
That's
And when
impossible.
did ever we decide that the 5th or the 7th or the 15th was going to be enough now? And so I think, I'm on another rabbit hole now, but just back to the social media thing, Grant, because that's interesting. We did a study that I was on and we released it, I think it was early last year, looking at social media. And we chose the 3 months, the March, because that's Endometriosis Awareness Month. So we did February, March and April around International Endometriosis Awareness Month. And we only studied Instagram. And it was a double-blind trial, a robust study. And we looked at various things that were posted about on Instagram over those 3 months. And one of those things was surgery, and looking at the accuracy and studying all of those things. So I know I was given the surgery component with another researcher who, and we didn't know each other. We didn't know who the other person was who got that. So we had to identify the symptoms and analyze it. And then we came together to assess and evaluate and write it up. Now, I know from that study that only 18% about surgery was actually accurate. So we have to be very careful and make sure that people understand that what they're reading on social media might not be, or on websites might not be accurate. So it's important then that I've got a sort of a set of resources that I like to call on that are well peer-reviewed and accurate and do encompass.
Can people find those online? Because there's the problem
help.
here, then I'm understanding it. So I get all that social media stuff. On the other hand, if your average time to diagnosis is 8 years or whatever it exactly was, as a young woman, I can understand why you're looking for other information.
Yeah, absolutely. Just absolutely going anywhere.
Rabbit hole, right?
Yeah. Well, I can certainly, I can talk to you about that. We're going to, work together. I can provide you with that information if you think it would be helpful to your students.
That'd be amazing.
Yeah, cool.
Awesome. Well,
We've just really only dented the surface of this thing.
It's interesting. Yeah, it's not a world I walk in at all. It's one that you're both in. But I sort of find this gap to get diagnosed, and then it's an invasive procedure, presumably with complications, to be diagnosed.
That may not even work.
That has a miss rate.
Yeah.
Actually, Grant, I will just say, because this is a great sadness to me, and I think a disgrace, that in New Zealand, even getting gynae assessment through our public hospitals is nigh impossible. So you might have actually gone to the GP. The GP, in all fairness, has exhausted all the possibilities, the tools that they have, the drugs that they might have at their fingertips to help you, refers on, and generally the letter comes back to the GP due to capacity issues. So when I hear things about waiting lists, my question is, what about all those who didn't make the waiting list? And that will be far greater for non-cancer gynecology like endometriosis than you could ever imagine.
Yeah, I don't know why we have to have, he says as a novice to the field, I don't know why we have to have a procedural diagnosis when there's a cluster of symptoms that no one is going to make up.
No.
I can't, it's completely beyond me, frankly. For many other things in the human body, we don't require that level of evidence. These are real things that happen to people, and we cluster those together, and away you go from there.
Grant, you've summed it up beautifully.
Yeah.
Absolutely summed it up beautifully. It's staggering, isn't it? Here's the cluster of symptoms. We think it's likely to be endometriosis. We've listened. We're taking action. We're following some guidelines, but the most important guidelines are what the people in front of us would really help. And that's not going to be just medical management, and it's certainly not going to be just surgical management. There's a whole raft of things we can do. I'm excited about taking this further at some stage. So, we've kind of...
Yeah, no, I agree. I mean, there's work to be done here.
So much work to be done.
And yeah, it's an astonishing thing to me as a male, because it doesn't come to the top of your mind every day, especially when you're not really involved in that. And I think you two are both like, what? Are you kidding me? But that's is a thing. So I hope more people than just people who are already thinking about endometriosis actually listen to this and start to advocate on young women's behalf, because we can do so much better. We should do, we must do.
Well, I think if it's about the purse strings, we've got a preprint of another study. I think I've released that to you already. It's about to be published. It hasn't been, but it is a preprint. But it is showing, and we use very, very clever people, scientists and people who work in the science of medical economy and that sort of thing. So incredibly bright, clever people, gynecologists, and they were in this study from New Zealand looking at the cost of the burden. So a pretty sad place to leave it. So I'm going to add one more thing, but that burden in New Zealand is 30 over 34.5 years. So 34 and a half years is out at 3.5 million per person.
Wow.
Over their lifespan. Now, if you take that as their surgeries, and it's it was a sort of actualized over productivity at work, so workplace, and evaluate and out over medical, productivity, influences that came into those lives at 3.5 million over 34 and a half years. Fertility, we didn't really get to talk about that. We can another time, but big cost with endometriosis, 1 in 3. So when we look at the cost, and if it's just bottom line that we're saying we need to do something about this because it costs us $3.5 million per person, and bearing in mind that there are tens of thousands. We used to say 120,000 15 years ago, before our population grew. So at least 120,000 plus people with endometriosis in New Zealand. At that kind of cost, you've really got to stick your head in the air and put your hand up and say, we need to do something about this.
Yeah, and of course there's a financial cost, but there's also the quality of life cost of every
Well, that
one of
burden
those
was-
lives.
Yeah, that burden was included. So it was the first study, one of the first studies in the world to actually include the burden of being the life burden, the personal burden.
Yeah, right. Okay, well, on that cheery note,
Well, I think we'll
you
leave
had
it
something
at,
else, Deborah.
yeah, I do. I'm going to leave it with your word, Kayla, because I don't ever like finishing like this. We're all going, oh, I think that word hope, because there is hope. When we know what to do, when we know what we can do and what we can do for ourselves with evidence-based work, then there is something that can be done. And that's what excites me. I don't like to I know that data, but I don't like to get lost in there, because we can provide hope. And the opposite of that is hopeless. And we don't want that.
No. And so, Deborah, if people want to learn more about Endo, learn more about you, where can they go?
Look, they can go to, they want to learn more about endometriosis in young people. I've got a website specific to this. So it's just periodhealth.nz. And they can go in there and they can start the course and they can play the games and do the gamification and do all the things. So parents and young people together can do that. They can also go onto my website, so epcoaching.com, and there's a contact form there, and I'd certainly be happy to take messages or something from that site too.
awesome.
Awesome. Thank you so much for your time, Deborah. It was so wonderful. And you're just such a wealth of knowledge in this space and so much experience. We feel very lucky to have had this conversation.
Oh, thank you so much. Gee, I've enjoyed this. It's been lovely. Thanks very much for your time. Thanks, Grant, for your interest. I really, and Kayla too. And, I think that there's a lot that we can do, and I'm looking forward to that.
Awesome. Hey, it's Grant here. Thanks for listening to the podcast. We don't advertise. We're never going to, but we have one request for you and one only. If you felt this show was worthwhile, can you please rate us, and please rate us 5 stars? That's it. Thanks very much.